Afternoon. Welcome to our first in a series of Facebook Live. My name is Elisa Brownlee. I am an assistive technology specialist with the ALS Association, and it is my pleasure to be here with Dr. Terry Heiman-Patterson and Dr. Sarah Feldman at Temple University Hospital. Thanks to an educational grant provided by Cytokinetics, the ALS Association is pleased to bring the first presentation in a three-part Facebook Live educational series to the ALS community. A 15-minute question and answer session will follow today's presentation. You may ask a question by typing into the comments section during the presentation. I will also ask questions submitted by the community prior to today's event. Today's presentation is being recorded and the video will be archived and available for viewing in the video section of our Facebook page. I'm excited to introduce today's presenters. Dr. Terry Heiman-Patterson is the director of the Center for Neurodegenerative Disorders, professor of neurology, and director of the ALS Center of Hope at Temple University in Philadelphia. She is joined by her colleague, Dr. Sarah Feldman, DPT ATP, a physical therapist and assistive technology professional at the ALS Center of Hope. During today's presentation, entitled Promoting Independence, they will address some of the challenges ALS presents, like neck muscle weakness and changes in upper extremity function. They will discuss how to maximize independence and quality of life, including the use of assistive technology and environmental controls. It is my pleasure to introduce Drs. Feldman and Heiman-Patterson.
Thank you all for joining us. We're really very excited about this. At our center, we really push to maximize independence and quality of life. This is really important to us because if I don't have a cure, I have treatment. Treatment is slowing the disease down, but also allowing people to live with ALS. And so to begin with, we thought that we would talk a little bit about what is it that causes the problems with mobility, with use of arms. You know, what's the underpinning neurologically? And you all know that it's really damage to the motor system. This is a motor neuron disease, and the motor system is composed of an upper motor neuron, which carries messages from the brain into the lower part of the brain and the spinal cord, and the lower motor neuron, which brings that message out from the spinal cord or the lower part of the brain to the muscles so that you can move. And in ALS, these two types of nerve cells degenerate and are damaged. And what causes that damage? Well, we don't really know, but we have lots of ideas. So you can see from this slide that everything from the powerhouse of the cell, mitochondria, not working, inflammatory mechanisms, that's what microglia or inflammation cells in the brain, the way the cell makes RNA and DNA, the way that works, the way the nerve cell transports cargo back and forth to the muscle can be involved, the way proteins clump in the cell, the way proteins are made, the machinery for making proteins can be damaged, and importantly, something called oxidative stress and something called glutamate excitotoxicity. Why do I talk about this? Because right now we have drugs that are available that can slow the disease down, that have been approved by the FDA. Radicava, the newest drug, first drug in 20 years, as I'm sure all of you are aware, attacks oxidative stress, we think, and is a free radical scavenger. The other medicine that's been around for years and consistently shows a modest effect on disease is called Riazole, and it works by reducing glutamate excitotoxicity. Glutamate is normally needed for communication between nerve cells, but if it accumulates in excess, it can damage it. And so we call this excitotoxicity. And riluzole works by somehow reducing glutamate excitotoxicity. So we don't know the cause, and that's been part of the problem finding the cure, is that perhaps everybody has a little bit different disease and there are many mechanisms operating. But we do have things that we can do. So what is it about losing motor neurons that limits your independence and that causes problems? Well, when there's damage to that upper motor neuron, you get stiffness, and the docs will call that spasticity. It's like walking in molasses or in cement. And it also causes you to have your balance be off, and you won't be as facile with your movements. You'll have trouble doing movements that are fine movements because of the stiffness. And, you know, when we actually examine you, we may find increased reflexes because of this damage. And damage to that upper motor neuron, this cell right here, this set of cells right here, can also cause cramping. So some of those cramps that people get can be due to that damage. In terms of the problems that you get when you have loss of these lower motor neurons, the ones that come out of the spinal cord in the lower part of the brain and carry the message to muscle, you get thinning of the muscle, or atrophy is our doctor talk, twitching, but that also can cause those cramps, and that's what's responsible for weakness. So it's this combination that leads to problems with motor function, and that we have to fix, and that we have to address and strategize on how to allow you to be independent despite these changes. So how do we address these changes? Well, I'm going to start by just saying cramps, we have medicines, and stretching is really important. So that can help sometimes alleviate some stretching. And you want to avoid the things that trigger it. For many people, if they make a sudden movement, that's what triggers their cramps. So trying to avoid those kinds of initiating factors. For spasticity, again, we have medicines. Those medicines include baclofen, Xanaflex, Dantrium, and in some cases we even use Klonopin or benzos, but usually we use baclofen as our first line. And stretching. And so, you know, that's why we stress stretching is really because it can help the cramps and the stiffness. But what about the weakness? What do we do to circumvent what's been going on and really impacts on your independence and the ability to do things? And, well, we do a lot of things. We have bracing and orthotics. We work on your activities of daily living. We talk about assistive technology, how to get around the fact that we can't do a particular movement. And we also are going to talk a little bit about assistive technology for environmental control. And I'm going to have Dr. Feldman talk about some of the ways for each of these areas that we can promote independence. And we're going to talk today about arm and neck, and future Facebook Live presentations are going to happen about some of the speech and swallowing functions and walking and gait. We're focusing on arms and neck today. Sarah?
Thank you very much, Dr. Heiman-Patterson, and thank you, Elisa. So today I'm going to start with, let's see. The neck support. So if somebody's having difficulty with their neck and they're having weakness with their neck, we start with mild support first, which is like a soft collar, and then move on to more supportive collars. A soft collar is just a foam collar that you can pick up at a pharmacy, and it offers mild support. The next collar that you might see, this is called a Headmaster Collar. I'm going to be talking about a lot of pieces of equipment today. It may seem like I'll be talking about everything that's out there, but I'm not. These are all just kind of samples of what's available. But these are ones that often we find work the best for people. This is called a Headmaster Collar, and people like it because it offers a little bit more support because it's firmer, but at the same time it keeps that openness, especially if you don't like things around your neck. And like Dr. Patterson mentioned, you do still want to keep stretching. We also recommend heat and stretch. This is a Vistat collar. It offers the most support out of these three. And you can see how I really am not moving a lot in this brace. So this collar offers the most support out of those three. In addition, you might find that you need support in a wheelchair. And this is a nice adjusted plush from the Whitmire, and it's soft and it can be adjusted. You would adjust it and then tighten up. It wouldn't flap like this. And another one is the Savant. And if, Elise, if you want to just show the slide, it has the different names of the collar. So next, now we're leaving the neck and we're going to go down to the arms. Now at our clinic, Mark Gorin is our occupational therapist, and he does a fantastic job of talking with people about their activities of daily living and taking a look at their arms. So most of what I've learned about this, I've learned from Mark. The first piece of equipment is missing. Hang on. Whoop. All right. So if you have hand weakness and you're not able to grip anymore, one of the braces that Mark might show you is called a universal cuff. And that just slides on your hand, and you can put anything into that cuff. Here I have a stylus that I would use on an iPad. You can put a spoon in so you can continue to feed yourself. You can put a pencil in and use an eraser to type. But if you also have wrist weakness, so say it's not just the grip, but now you also have difficulty holding your wrist up, you would use a dorsal wrist support. And this attaches on like this. And then it will also, dorsal, thank you very much. Wait, this is live, we can't change that. Dorsal wrist support. And again, you could put something into that pocket so that you don't have to grip it, and it will hold it for you. And then in the next piece, so that's if you have hand and wrist weakness. And then if you have shoulder weakness, this is a mobile arm support, and it would clamp onto a desk. It doesn't quite clamp onto ours here. And you rest your hand on it, and you're able to move your arm like that to type or to do any other activities. So that's a mobile arm support. So again, I do have some of that information. You can use it to eat as long as it's at the same level. I do have some of the information on this, again, on the slide. So since we're talking about functional independence, a lot of what we're talking about with activities of daily living are eating, grooming, bathing, and dressing. Those are the 4 big areas that Mark addresses when he sees somebody in the clinic. So for eating, again, you might want to use those braces that we just showed. There's also adaptive spoons, forks, so they have larger grips. So making something so it has a larger handle makes something easier to grip. Just like Dr. Heiman-Patterson said, sometimes the fine motor coordination is what it becomes difficult, but using a gross grasp is still available to the person. So using larger handles. You could just take pipe insulation and put it around your different, like if you want to continue to use the same silverware, and do it that way. In addition, changing the place that you use, so using a plate that has an edge around it makes it so you can actually push the food into the edge rather than pushing it off, and using something like this that's just that sticky shelf paper liner helps to keep the plate from moving. So while you're pushing into the plate, it holds it still. In addition, there's cups with straws so that you don't have to, you can just get your liquid like that, and they have longer straws, and they also have straws that once you suck the liquid into it, it stays at the top. There are feeders available. We don't use them that often, but they would be electronic, and they would bring the food up to your mouth. They tend to run over $3,000, and again, we don't use them very often, but they are available, so I want you to know that. In addition, sometimes people will get a peg so that if they're having difficulty moving their arms up and down, they can still feed themselves. They can still get their own nutrition. And Mark has worked out different ways for a peg to be held up, maybe with a Bunsen burner holder or things like that, so that somebody can still do the peg feedings on their own, the tube feedings. For grooming, the same thing. So you would do braces to help, making things fat again, adapted large handles. So if you're having difficulty shaving, use an electric razor, difficulty brushing your teeth, use a fatter handle like an electric toothbrush, or put this on your regular toothbrush. There are devices too that you can use. This is can you see that?
Mm-hmm.
This is a button hook. And so if you have difficulty doing this pinch, it's a button, you slip it through, grab the button with it. It takes a little practice. And then pull it back through. So if I can't use the pinch on this hand, I would use a gross grasp on this hand. It also has a zipper pull on the other end. So you would hook that into your zipper, or put a larger hook on your zipper first and then use that to pull up and down. Sometimes people will use mounts for their hair dryer. So if they can't hold the hair dryer up anymore, they'll attach the hair dryer to a mount so they can do that. And many of these adaptive things also people can use if they want to do their makeup. So they could use a universal cuff and put a makeup brush into that and do it that way. And that leads right into dressing. And we do have what we call an ADL kit, where it has elastic shoelaces, it has this button hook that I talked about, a long handled shoehorn, certainly using Velcro in place of buttons or snaps is a good option for people. And you can now buy adaptive clothing. And one of them is Tommy Hilfiger came out with adaptive clothing, and that has magnetic connections instead of buttons. So for independence with bathing, we always recommend grab bars, tub transfer benches. You can use a long-handled sponge so you can keep washing your feet, and a handheld shower, which if you're not able to hold it on your own, perhaps you can at least mount it down so it's a little bit lower. So those were the main devices that I wanted to talk about for independence in your ADLs. Now I want to talk about computer access. So a lot of people want to know, how can I keep using my computer if I'm having difficulty using my hands? And I want you to know there's things that are built into your operating system. There's hardware or software that you can add, and of course there's voice activation, which kind of encompasses both. So for the operating system, at least if you can keep it up there on the computer,
Oh, sure.
I'll go ahead and do something I didn't want to do. End my show. So if you go to your Start menu, to Programs, under Accessories, see that? See that? There is an Ease of Access Center in the operating systems of all Windows computers. So right within the computer itself, you can find these different options. So I can pull up, I have to do it again. I can pull up an on-screen keyboard. And then anything, I can use this to type. using my mouse instead of using my hands. So any program that I open up, I can go ahead and do that. Now, and there it is. It stays up there until I get rid of it. Now my Mac, don't step over my... The same thing for... do you want me to bring this over here? Can you see that?
Mm-hmm.
So if you go down to, again, on a Mac, you go to the System Preferences, and right there is Accessibility. It's built into the system. It comes with it. You don't have to pay anything extra, and it gives you several options. In here, it gives me an option for a keyboard as well as switch control, many other things. So built into the system themselves are the ability to do accessibility. Now for a tablet, you have to remember your password. Don't look at the password. There's also accessibility settings. Right there. And it gives you all these different options. In addition, I gotta get. Android does as well. I just don't have an Android tablet here because my daughter has it. There we go. In addition, there are different mouse options that you can use. You can use here they are over here, trackball, mouse. So people can use their camera as a head mouse. Let me come around again. This is a head mouse that I really like. It's called a Tracker Pro, and it's just plug and play. You can plug it in. It is $1,000, but you just plug it in and go, and you can use it right away by putting a reflective dot on your head, and then you can see the, let me just get one out. You can see me moving the cursor. Can you see that from behind? I'm moving the cursor with my head. Here's my hands. So those are some alternate mouse options, and they work really well. And also the power wheelchairs. A lot of times people have the option to use their joystick as a mouse control. You can see this option in that in the power wheelchair. Voice activation, I didn't used to talk very much about voice activation because, as we know, people's voices change with ALS. However, they've gotten much better, and now you can have them in the operating systems themselves. There's very exciting alternate mouse access that I'm just learning about. For Android phones and tablets, it's called Sesame Enable. It's a $20 a month subscription for an app, but you can do everything with your head. Excuse me. The same thing with eye gaze. So here's two different, many people know about eye gaze as far as with the communication devices, and they may be familiar with that because people with ALS a lot of times have communication devices and use an eye gaze, and then that you can use that as well to go on the computer. But there are also, Toby also makes an eye gaze piece that can be added to a computer, and then that can be used for hands-free access even if you don't need it to communicate. And then a very exciting, in the future, something that's coming up right now is Windows 10 has beta eye control right now where they're testing out eye control. So that it would come, again, it would be part of the operating system, and then you would have to just get the eye gaze piece to go on to use it. So I'm very much looking forward to that. There, in addition to the external mouses, you can also get virtual mouse and a virtual keyboard. So we showed you the on-screen keyboard already, and then this is what an on-screen mouse would look like. So you would pull that up, and then if you were using the head tracker, for example, you would move the cursor with your head and then choose whichever one. This would be left click, right click, and that's a free download. And this is what it looks like if you're doing kind of a dwell, so you hit it and you need to use a switch then, switch control for the mouse. And we'll talk a minute about switches. I know, come back over here. Here are a variety of switches, and what switches do is they allow you to cause a click or like a button press or something that you can't do anymore. If I can't do that tiny movement, maybe I can do a big movement with my hand. Or this is a tiny little button click, so if I can still move my finger a little bit. This is a very light, micro light switch. And this one is a tilt switch, so it has a sensor inside that knows when you're tilting. So any of these can be plugged into using your computer as an alternate access. So if you move the cursor with your head, and then once you get the cursor where you need it, you hit the switch. Now, I say that it can be plugged in, but just so you know, you can't directly plug one of these switches in. You have to either plug it into something else first. And this is just a switch click, which allows you to use a big button or plug it into this first. And then there's another one too that's called the Tapio that I don't have. I wasn't able to find. And this is a treadle. So say you can still move your head to move the cursor and then step on that, just like a sewing machine kind of switch. So those are all switches. Now for an iPad, since this doesn't have a mouse and it doesn't take the, you can't plug one of those switches in, you can plug in something that's like a hook and plug that into the port, plug the switch into this, and then you do, again, the scanning. So see how this is scanning across there? I would stop it when I want it to stop whatever I want to choose. Now I'm touching it because I have it set up right now so the whole screen is a switch, but you could set up any of the switches to do this instead. And I just wanted to show one other switch that I couldn't show here and how somebody's using it. So this person couldn't hit that tiny button anymore to turn their wheelchair on and off. So we set up a micro light switch so she could just whack it with her hand, and you see how it's turning it on and off. So that's another way, that's another use for switches. And the last piece is environmental control. So again, built into the AACs sometimes, and I have one over here that's kind of set up. It doesn't have much battery. Okay. So this is a speech generating device, and it is an eye gaze, but I just want to show you that they have different environmental controls that you could use using your eyes. So you could go to the TV remote, for example, or different for different control options. In addition, power wheelchairs. Again, I showed you the mouse. They can also use home controls for that. Tablets and smartphones have, let me get out of this. They have different ways that you can control things in your home. So you can go to My Home and you can set up lights. You have to get the devices, and I'll talk about that in a minute. But you could run it then, if you can touch the screen on your iPad, you can run that, or touch the screen on your phone. You can set up different devices that you can run through your phone. And then the last for home Automation is the smart speakers. So things like the Amazon Echo or the Echo Dot. This is an Echo Dot. So I would say to the Echo to Amazon that I wanted to run something in my house, and then it would turn the lights on and off. Now how that works is I talk to the Echo, and then it talks to one of these, like I would have a plug in my office, for example, and then I would put this in, wirelessly hook that up, and Elisa know how well that goes sometimes, and then when I say turn the off, I would call it office light, turn the office light on, and then it would turn the office light on or off. And again, that you do need internet, you do need wireless for that particular piece. But the nice thing about this is that the Amazon Echo, if you're using a speech generating device, you can speak to this and have it run something in your house. So it doesn't have to be your natural speech, it could be speech generated through a computer or a phone as well. And Google Home is another one. Amazon Echo is the one I have here, but Google Home is another one. And you can control many different things that way in your home. So that was what I had for all the independents.
There was a question on
Yeah.
how do I find local resources for all this, because it's overwhelming.
Yeah, so any one of these areas, I have to admit, could be a complete session itself. It could be. I could talk for a half an hour about how to access something on a iPad. So if you have a local ALS clinic, they should certainly have somebody there who's available. Elisa and I both have some information on a lot of all of this. They could certainly reach out to me with questions. But usually if there's somebody who's working with the assistive technology at the clinic or locally, that would be good.
The goal of this whirlwind tour also is to show you the amount of available equipment that you can investigate, and to give you a sense that there are things out there that are actually within reach and affordable and available now. And so I know that the way we feel is anybody contacts us, we'll give you information on how to get specific equipment to address whichever one of the areas that you're most interested in. But knowing that it's available and that there are resources to help you be more independent is really the goal, and to show you the depth and breadth of what's available and the spectrum. And so specific questions, could be addressed to Sarah or your own professionals at your clinic. I'm having trouble with computer access, and I saw that there were these switches that I could use, and then slowly those switches can be gone over by your professional at your clinic, or if you want to email Sarah or I, we'll help you out and get you connected and give you information on where to get these things.
So there was a question as to why does somebody's voice change in pitch and tone?
Because our pitch and tone is controlled really by the muscles of the back of our mouth and how the vocal cords are held, and also by how much air we can generate over those vocal cords. And as weakness occurs, that can affect the volume of air going over the vocal cords and the way the vocal cords can move and the way your soft palate moves to control air going over the vocal cords. So typically people's voice will get more nasal, like that, or the spasticity in the tongue movement will also be evident, and it'll be difficult to pronounce words. And so there are these changes that are a combination of that stiffness I talked about from the upper motor neuron and the weakness in the lower motor neuron. So in order to phonate, I need my facial muscles. I'm making lots of faces now. I'm practicing for my grandchild. And I have to move my tongue around. And if those muscles are weak, I can't phonate well either. So it's really multifactorial and a combination. And that's why we didn't talk about it, but I'm sure it'll be covered in one of the other webinars, voice banking. So, you know, in addition to the aids that we talked about, you can actually get a device like the MyToby with your voice on it if you voice bank. You can access your MyToby many ways, and that's what Sarah was really pointing out. You can use one of our mouse switches. You can use a head eye gaze, a head mouse. There are many ways that you can access it depending on what level of function you have in any particular instance. So, you know, and that's really, you know, the healthcare professionals at your clinic will be able to look at you and say, this would work best for you, or at least give you some guidance. Nobody would expect you to go out and hunt it down yourself, and certainly we like to help guide people on where to look for things in our center.
Sarah, somebody asked, are these items available for loan through state loaner programs?
Some of them are. Some of them are. It, of course, varies state by state. I know that the Pennsylvania Initiative on Assistive Technology does have things available for loan.
There were a couple of comments about cannabis and ALS and helping with symptom
Cramps
management.
and spasms.
Yes.
It is one of the indications for cannabis, and some people have even bought CBD oil online and found it to be helpful. And so, yes, and actually there's what we call cannabinoid receptors in the brain, and some people have even considered it for therapeutic intervention, not just for cramps, but disease modulation. And so it's interesting, and I certainly, in talking to my own patients and people I take care of, if they're having a lot of pain issues and stiffness and they want to try cannabis, I think that's a reasonable thing.
And Sarah, one person said, can you please show the iPad again? I believe it's about switch scanning.
Mm-hmm.
And where it is in there.
Oh.
That's right, don't show everyone your password.
So it's in settings, and then accessibility. And you can do switch control. Assistive touch is nice as well, because when you turn on assistive touch, it puts the home button right there on your screen, and it stays on your screen. Do you see that?
Mm-hmm.
And then what's nice about that is that if you need to use a stylus, if pushing is hard, then you just have to touch that, and it pulls up your home button.
Great. Thank you for showing that again. And I don't believe we have, it says affected vision, hearing. Vision and hearing, not
Are they
affected?
No.
Okay.
Vision and hearing are not affected by disease.
Okay. And somebody commented that Toby does have a loaner program sometimes too.
Okay, great.
So can the state AT loan program put a link to its available equipment on the ALS webpage? If you don't mind, I'll answer that. Every state is different, but I believe in the future we're going to have a link to every initiative on the Assistive Technology initiative on the webpage. So it doesn't look like there's any more questions here. Do you guys have any?
Yeah, I was just going to talk about that.
Okay.
I wanted to save some of the future things for,
Sure.
you know, I didn't want to run out of time.
No, we're
But
good.
some of the exciting things, in addition to, I talked about the Windows 10, which I think is fantastic that they're working on getting that, the eye gaze software in their operating system. There's a lot of makers, there are a lot of students out there working. I know Elisa's worked with biomedical engineering students. I have worked with biomedical engineering students. They're doing a They're very exciting. Right now, they're very expensive still, but they're great products, and I'm looking forward to seeing more of what works with that. 3D printing, I think, is really something that we're just starting to get excited and work with. So if somebody has difficulty using a specific product, we can actually customize the way that they're going to access that or hold on to that. We can make it to their hand. Perhaps we can customize a neck collar. There's a lot of customization that can be done with 3D printing, and I'm really excited about that. But again, we're just kind of starting with that. And then the brain-computer interface. So right now it's being used a lot with not a lot with communication, but it's being primarily looked at for communication. But I think all these other things, like controlling something in your home or being more independent, is going to be the next step with brain-computer interface. So I wanted to let people know about some of the things that I get excited about for our pals.
And I'm going to come over here, and there was another question for Dr. Patterson. And it says, I am a bulbar patient. Would I have lung and breathing problems quicker than someone who does not have bulbar symptoms?
You may, but not necessarily, but you may. And it's mostly important because of your bulbar symptoms, if you have a lot of secretions, to really take good care of them so they don't get into your lungs, because that's called aspiration, and that can really impact on your breathing, as well as the muscle weakness in the muscles that help you to breathe, and in your airway maintenance. So the short answer is you may, and there are a lot of statistics, right? And we can quote a lot of statistics, but you are you, and I think that being vigilant in every individual's case for the complications that can occur is what's most important to really promote a quality of life and independence for as long as possible. We like to say we're making it about living with ALS at our center, and I think that's really important to address the needs and be proactive about the complications.
Somebody asked if they can get an email of the slideshow. Can we put a link to your web address?
Mm-hmm.
Okay, we will do that. And if anybody else has any questions, please type them in the comments. Otherwise, we will be winding this up. Do you have something else to say? No? Well, I want to thank you, Dr. Patterson, so much, and Dr. Feldman. I really appreciate this. The next presentation of the Facebook Live series will be in August, and you will be receiving information about that. So I want to thank everybody for joining us this afternoon, and really thank you, both doctors. Really, we really appreciate this. One more question, sorry. Okay, somebody just got it in on time. Is there research involving, I don't know what that is, CRISPR and ALS?
CRISPR.
Oh, CRISPR.
Okay. But so CRISPR is a method to take genes in and replace them with something else, so you can edit. It's basically an editing tool for the DNA, which is really how we write our genes. DNA contains all the information, like a book on how to make proteins and put them together, and that's called DNA. And CRISPR is a way to edit that. It's kind of like reading a book and seeing a mistake in a word and editing that word. So right now, CRISPR has actually been used to treat a disease, what we call mucopolysaccharidoses. And certainly, once you apply a technique to one disease, that tool, you learn something about how to use that tool, and you can take that tool and use it in other genetic illnesses. And so the hope is that, yes, someday we would be able to use CRISPR to treat people with genetic forms of ALS. And how would that happen? So we know somebody has an abnormal gene. We would use the CRISPR technology to cut out and edit our DNA, take out the bad gene, and then replace it with a gene that perhaps is more properly sequenced or gives the right information for making that protein. We also, though, are doing other genetic modulation, and there's now 2 exciting trials that are in different stages. One is for the genetic mutation SOD1, and it turns out that was the first gene we ever learned about back in 1993, and in terms of hereditary ALS. And it turns out that gene, even it's abnormal, and it still works to do what it's supposed to do, which is kind of to reduce oxidative stress, to clean up free radicals. The problem is that with the mutations, it takes on some other toxic function as well. So it does its job, but it does something else as well. And it also turns out that you don't absolutely need to have SOD1 in your body to live. So the strategy is being used to knock it down, what we call antisense, which is to block any SOD from being made. And that's now going into phase 2 in people in families where there's SOD mutations. So that's really very exciting. And the other disease or the other gene that's being looked at for a similar technology is the C9 ORF72 repeat disease. So this is also a genetic abnormality that can underlie ALS. And the exciting thing here is that this is probably the most common of all the genetic defects in ALS, and it makes up 40% of hereditary ALS, and actually even in people who have no family history, upwards of 4, depending on who you read against statistics, 4%, 7%, or even as high as 10% of people with sporadic, out of the blue ALS carry this mutation. And we now have a clinical trial going on where the extra DNA, this gene has extra DNA. It's called a repeat disease, and there's a repetitive portion of DNA within the gene that shouldn't be there. And that's felt to be the kind of culprit, the driver for the disease, because it causes the body to make abnormal little proteins called dipeptide repeats that may glom things up. And we now have a strategy where we're blocking the production of those dipeptide repeats. And so that is really exciting. So while we haven't done CRISPR yet in ALS, we are doing some other genetic modulation that's really important and exciting, and will set the stage for us to really deal with all of the genetic defects in ALS and have strategies when we can find genetic abnormalities. I hope that was helpful. You got me going on something I'm really interested in.
It was very, and so somebody followed up with that and said, because of the CRISPR, where do you think we are with the cure in terms of the CRISPR and all the research that's being done?
You know, because ALS is a very heterogeneous disease. I mean, I've got a big barrel, and it's got fruit in it, and it's all called ALS, but it's got apples, oranges, strawberries, peaches, you know, everything in it. And that's the real problem, because there's no one-size-fits-all, I don't think, for treatment. But with these genetic sort of directed treatments, I think that's where we're going to see our greatest strides first, is in the genetic variants, because we at least have a target, a real target. So I do think we're moving along, and certainly for SOD1 and the C9, we're really on our way. CRISPR is only going to be able to help for known genetic problems. So while CRISPR could be really useful for, we've identified, let's see, 34 or more genes now that can cause ALS. For those 34, certainly some of them would be treatable with CRISPR technology. There's also the other 85 to 90% of people who have sporadic ALS, and we have to figure out biomarkers and ways to get at those people. Remember the slide I showed with all the different causes of ALS, or all the different, I should say, mechanisms that probably drive the motor nerve damage in ALS. Well, everybody may have a different mechanism. You know, we have a group of people with ALS, and 10% may have inflammation, 10% may have oxidative stress, 10% may have excitotoxicity, that glutamate drive their disease. And so until we can find ways to sort through what the most important mechanism is in any individual ALS patient, that's when we're going to make real progress, and we're getting there. That's what, if you're going to a clinic that's doing any of the biomarker studies, please participate. This is all directed at identifying ways to stratify people with ALS so that we can better understand each individual disease. Personalized medicine is going to be the key, and we'll get there with the work that we're doing in biomarkers. And I would say that in the next 5 to 10 years, we'll see major strides in really being able to do what's been done in cancer and in stratifying.
So we'll wrap it up with this last question from a person. Any idea why veterans have a high incidence of ALS compared to the civilian population?
There have been theories, but the short answer is we don't know, and the Gulf War veterans seem to have the highest incidence, but all veterans are at risk. I have personal biases, but I don't know the answer, nor does anyone else, and there is active research going on. My personal bias is, you know what, we're all born with a genetic endowment. That's why some of us are going to get heart disease, some of us are going to get diabetes, some of us are going to get tumors, some of us are going to get ALS. And we have a genetic endowment that gives us a propensity to develop a particular disease. And in the proper setting and milieu, our genetic background and an environmental stimulus triggers a disease. And I would suspect when we really peel away the onion, we'll find out that there's some genetic predisposition to some environmental exposure that people are getting in the service. But I don't know the answer. It's a guess, and it needs work, and it's something that should be followed up on because it will give us clues to disease mechanisms.
And is the disease predominantly Caucasian?
I don't know what the statistics are. The short answer is it doesn't only affect Caucasians. That's for certain. And I don't think I think by numbers maybe it is more Caucasians, but I'd have to look up the epidemiology on that. I'm sorry.
No, sorry. It was our last question. Again, thank you, doctors, very much. And I just want to conclude this Facebook Live presentation by telling you our next presentation will be Monday, August 13th at 11 a.m. Eastern Time with Dr. David Walk from the University of Minnesota in Minneapolis, and he will be addressing respiratory and bulbar function with people with ALS. So again, I want to thank you for joining us today, and thank you, Dr. Feldman, thank you, Dr. Heiman-Patterson, and we will, this video is being obviously being Facebook Live, but also has been recorded and will be archived on the ALS Facebook page, and will also be available on YouTube. Thank you very much.